I'm Adam Brimelow. I'm Director of Communications at NHS Providers. I'm really delighted to be with you and to chair this session. We welcome our panel, Toby Lowe, who is a visiting Professor of Public Management at Centre for Public Impact. Cathy Elliott, ICB Chair Designate at West Yorkshire and Harrogate ICS, and James Drury, Director of Partnership Development at Bradford District and Craven Health and Care Partnership. They're going to speak to us about provider collaboration and simplifying complexity. So just by way of overview, in delivering good governance, simplicity is nearly always preferable to complexity. However, system working will necessarily bring with it a degree of complexity. And this session examines how we deal with complexity, as well as examining the possibility of simplifying system governance. And the way we're going to proceed is we'll have some presentations from our panelists. Toby will start, and then Cathy and James will be doing a double act to follow up. Toby will be speaking for about 12 minutes, and then we'll have about a quarter of an hour from Cathy and James, and then we'll move into a sort of panel discussion with opportunities for wider Q&A. So please do, if you think of some questions you'd like answered, we're really interested in getting a good discussion going. So without further ado, I'm going to hand over to Toby Lowe.
Thank you very much, Adam. Good morning, folks. Thank you for inviting me to speak with you this morning. So I'm going to talk with you about the way that outcomes in the world are created and how the governance of your systems can help or hinder that process. So next slide, please. So the kind of questions that I'm going to ask are, how can public service help people to create real outcomes in their lives, and how should you manage it to enable that? And I'm going to start with exploring how an outcome is made, then look at how learning as a management strategy enables you to achieve that outcomes, and a bit about how you can change your public management approach to enable the creation of real outcomes in the world. Next slide, please. So the message from across the work that I do and this presentation is, if we want to achieve real outcomes in the world, we need to do public management very differently. So what do I mean by that? Where should we start with exploring that idea? Next slide, please. Oh, next slide, please. Thank you. So where's a good shared starting point for that conversation? Well, I think that this statement is pretty uncontroversial now, that the purpose of public service is to help people create good outcomes in their lives. So if we start with that as our kind of foundational belief that we all agree with, what's the next question that we ask? Next slide, please. So then the next question asked is, okay, how is an outcome created? Because if we agree that outcomes are important, then by whatever process outcomes are made, that's what our job is, and that's what the job of management and governance is to support. So next slide, please. So this is our best understanding of how an outcome is created in the world. Those of you in the public health world will recognise this. This is the systems map of obesity produced by the UK Government Office for Science in 2007. It's what happens when you shut a bunch of public health people in a room together and say, you're not allowed out until you've mapped all the causes of the outcome of obesity and all the relationships between all of those causes. 108 different factors they managed to map on this systems map. And you can see them summed up into things like early life experiences, food production and supply, macroeconomic drivers, education, media, technology, the nature of work, built environment, and healthcare and treatment options. And what you'll see really clearly from this diagram is that an outcome in someone's life, like obesity, is the product of all of these factors working together. So an outcome is the product of a whole system working together. And look how many factors out of that 108 are about healthcare and treatment options. Four factors out of 108 that produces the outcome of obesity are about healthcare and treatment options. The rest are the products of a much broader system of interaction of factors. So, next slide, please. This has really, really strong implications for how we do public management. So this is, again, key message of the of this presentation. You can see, I think it's a key message because it's in big red shouty capital letters. Outcomes are not delivered by organisations. The outcomes we desire are emergent properties of complex systems. This is the reality of how an outcome is made in the world. So this is a reality that we need to face if we want to create good outcomes. Next slide, please. So what implications does this have for how we do public management? Firstly, really important, a delivery mindset is not helpful for creating outcomes. If we have in our mind a delivery mindset that we have to hit, like we have to identify particular KPIs and hit those, that's what our management practice is, that will not help us create real outcomes in the world, because if outcomes are emergent properties of complex systems, we cannot specify the delivery points in advance and run them to timetable. It is simply not how the world works. So you can't contract an organisational programme to deliver an outcome, because if you try and contract healthcare organisations to deliver the outcome of obesity, for example, there are only 4 factors out of 108. It is impossible to contract an organisation to deliver an outcome. But we know what happens when organisations, when governments and other bodies try and contract and performance management for outcomes, because there's a ton of evidence about it. Evidence. If you try and hold people accountable for creating outcomes, essentially you're holding organisations accountable for things they cannot control. And the evidence, every single bit of evidence around this says that what happens is it creates gaming rather than real outcomes. So it turns everyone's job into the production of good-looking data rather than creating real outcomes in the world. Again, it's not really a matter of opinion. That's what the evidence says. Next slide, please. So, if public service wants to help people create real outcomes in the world, what should it do? And so our message to this, and what organisations have been trying to find this do, is we need to embrace the complex reality of how outcomes are made, because that's how the real world works. Next slide, please. So rather than doing as the little managers in the box have been encouraged to do previously, and pretending that the world is simple and linear, and that if we do A, then outcome B will happen. It's just a management fantasy. It's a management fantasy. What we need to do is open the door to the complex reality of how the world actually works. Next slide, please. So this is what we've been exploring with a range of public service organisations from around the world. What's a different approach to public management that actually enables the creation of real outcomes? And we call that approach human learning systems, and we describe it as public service for the real world. You can see more at humanlearning.systems. Next slide, please. So let's zoom into this question. How is a desirable outcome created in each person's life? Because if we want to manage the creation of real outcomes, we need to do this. So start with the recognition that each person's life is a unique, complex system that creates outcomes. Well, what does that look like? Next slide, please. So this is a representation of a person's life as a system that creates the outcome of well-being or not. So down the left-hand side, you see all the factors, you see all the actors in that system that can produce the outcome of well-being or not. So it starts with the person themselves, their family and friends, and blah, 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 and goes through, including their health agencies and various things like that. And down the right-hand side, you see the factors in that person's life that produce the outcome of well-being or not. Their income and wealth, their employment status, their housing conditions, blah, blah, blah. And all of these things interact in each person's life as a unique, complex system to produce the outcome of well-being or not. Next slide, please. So how does public management respond to this reality? Well, what we've seen, and this is where we can start to simplify things, is learning is the management strategy that enables us to create outcomes. What does that look like? Next slide, please. So what we've seen is that it's learning as a management strategy starts by framing each public-facing worker's role as a learning cycle. So as a cycle where the job of the public-facing worker is to build a learning relationship with the person they're supporting, understand their life as a unique, complex system that produces one outcome and tries to produce a different set of pattern results, a different outcome. So we understand their life as a system that produces an outcome. We co-design experiments with them to see whether we can get their life as a system to produce a different pattern of results. We run those experiments alongside the people, and then we embed the results of those experiments in their life. So if I'm a public-facing worker helping you with your chronic pain, first thing I do is I help us both understand your life as a system that's currently producing the outcome of chronic pain. So I might ask you questions like, you experience the pain more in the morning or the evenings? Do you experience it more at work or at home when you eat these particular kind of foods, or those when you make this action or that action? Blah, blah, blah. Together we build up a picture of your life. Then we co-design experiments in your life to see whether we can get it to produce a different pattern of results, not chronic pain. So what happens if we try these physiotherapy techniques? What happens if we try fitting this enablement equipment to your house? What happens if we try joining this walking group or trying this diet rather than that one? We run all of these experiments in your life, see what works and what doesn't, and we embed the results of those experiments in your life as behavior change and structural change in the forces around your life. And because we've changed your life as a complex system by doing that, then the cycle starts again. So the first key change is to frame public-facing workers' role in terms of this learning cycle, so that people manage their work in terms of this learning cycle. Next slide, please. And then once the public-facing workers' role is framed as a learning cycle, then we can think about learning as a management strategy at different system scales. And this is where we begin to think about the relationship between organisations as systems. Next slide, please. So it's important to understand that when we say system, systems operate at multiple scales. So a person's life is a system, as I've just described before. Organisations are systems made up of lots of different functions. Places are systems made up of lots of different organisations. Countries are systems made up of lots of different places, right? And what we see is that each of these system scales, people are operating the same kind of learning cycle, that understand the system, co-design, run experiments, embed and influence. So let's look at what the relationship between learning cycles at different system scales. Next slide, please. So what we see is that to enact learning as a management strategy, what people are doing is creating connected learning cycles across the different system scales. So let's say from the person scale, the learning cycle for the chronic pain that I described before, to the organisation scale for an organisation that employs a bunch of public-facing workers whose role is framed in that way. What the organisation is trying to do at its learning cycle is to learn from all of the patterns of all of those learning cycles, excuse me, at the person scale. So if we're a housing association supporting lots of people in chronic pain, what do we learn from across all of those learning cycles about how we need to fit enablement equipment in people's houses? Also, we need to, as an organisation, enable all of those learning cycles to function effectively. So we need to do, our learning cycle is asking questions like, what's the maximum caseload for workers that enable them to run those learning cycles? What information systems do we need to share? What share reflective practice spaces do we need to enable workers to learn together? What staff capabilities do we need to recruit and train for? And those are the things that people are experimenting with at the organisational scale in order to learn from and enable the learning cycles at the scale below. Next slide, please. And so what learning as a management strategy looks like is people are creating a connected stack of learning cycles from the public-facing workers right through to the minister, essentially. So where the job of the learning cycle at each higher scale is to learn from and enable the cycle at the scale below. Next slide, please. So how does this relate to governance? Well, so effectively, the question that we're asking is to enable public service to help create outcomes. The governance question is, how do we govern these learning cycles? So some of the relevant governance questions that we've seen that get asked as part of the governance mechanisms for this are, what's the integrity of this learning and adaptation process? How is learning translated into change practice? How is our learning achieving our purpose? How do we know all of these things? These are the kinds of questions that the learning cycles at the higher scales begin to experiment with. And it's the task of senior leaders to experiment to find answers to these questions. Next slide, please. So who's adopting this kind of learning as management strategy approach? We've got over kind of 50 case studies from governments and public service agencies around the world. So if you want to do public management differently, it's just a choice. You can choose to do it differently. And these are some of the places that are choosing to do it differently. So within the NHS, Healthcare Improvement Scotland is choosing to do this differently. The Finnish National Agency for Education has chosen to do it differently. There's too many local authorities now in the UK to count, really, that choosing to do these things differently, including Plymouth Council, just happens to be Council of the Year last year, you know, no worries. Next slide, please. So if you want to try this for yourselves, if you want to choose to do public management differently as a way to create real outcomes in the world, we're producing, the Healthcare Improvement Scotland have commissioned us to create a how-to guide for human learning systems. That should be available for free download from late May. So it really delves into the kind of practical questions from the front line up through to the governance questions. And if you want help, you can ask some of my colleagues at the Centre for Public Impact, and you can just, there's a link there that will give you some sense of the different help available for different people. Next slide, please. And if you want, in the meantime, if you want to know more information about that, there's a ton of information about this human learning systems approach at that website, humanlearning.systems. And that's me done, hopefully, in 12 minutes.
Very good, Toby. Thank you very much indeed. I thought that was really fascinating. Looking forward to chatting a little more about that in a short while. But first, let's hear from Cathy Elliott and James Drury. Over to you.
Thank you very much. Good morning, everybody. I hope you're well. And thanks to NHS Providers for inviting James and I to come and talk about our West Yorkshire Health and Care Partnership. We're very proud of our partnership that's been established for 5 or 6 years or so. I'm Cathy Elliott. I'm Chair Designate of our forthcoming West Yorkshire Integrated Care Board. And James, would you introduce yourself?
Morning, everybody. I'm James Drury. I'm the Partnership Development Director for Bradford District and Craven, which is one of the place-based partnerships that's proud to be part of the West Yorkshire Integrated Care System.
Thanks, James. So what we're going to do is talk to you about overall our West Yorkshire Health and Care Partnership and our new Integrated Health Board and how that links in to our existing arrangements. And then James is going to give you highlights of Bradford District and Craven as one of our 5 places as the place-based system. And we'll touch on provider collaboratives that plug into our system as well. So if we can move to the next 2 slides. So that's who I am, and I'm going to talk about West Yorkshire. And if we move on to the next one, please. Just to give you some context, you may know West Yorkshire very well, but this is our geography. We have 5 distinct places. We've got 2.4 million people that we serve, an incredibly diverse rural and urban population, an incredibly diverse community as well in terms of particularly significant South Asian community across our urban areas. We have our 5 distinct places, and as I said, James is going to talk about Bradford District and Craven and their Act as One system partnership approach. We have 52 primary care networks as well, and we very much operate as a true partnership. It's what we've done for many years now. We're a true partnership. We work alongside our local authority leaders. We've had a partnership board in place for a number of years now, which will then become our integrated care partnership to link with our ACB, our integrated care board. And we've had a lot of particularly proactive working with our colleagues in the voluntary and community sector, as well as plugging in and integrating our NHS colleagues together. So if we move on to the next slide, there's just an overview there of our journey so far since 2016. And particularly about how we have been a coalition of the willing for many years now. I'll talk later about our values and behaviours that are really the bedrock of how we work together as system leaders and as system partners together. And I'll talk later about our strategy as well. So the legislation coming through gives us an opportunity to formalise a number of things, as well as bring in, obviously, the guidance that is coming through from government and NHS England at this time. So the next slide particularly gives you an overview of our 10 strategic ambitions. These have been in place since January 2020. They're currently being refreshed due to our response to the pandemic, as well as the variety of white papers that have come through. And as you appreciate, as a Northern integrated care system, we're very much paying attention to the levelling up agenda and the 12 missions coming from that. But these 10 missions are very much owned by us all. They're owned by people in the NHS, the voluntary sector, and our local authority colleagues. And these were signed off by our partnership board over 2 years ago. And if we move on to the next slide, because those of you who are governance geeks, I'm sure you're wondering how this works. And we're being asked to talk about the nuts and bolts of it all and trying to make something simple out of the complexity of working with thousands of people in our workforce and a huge number of different partners across the public sector and into the voluntary sector as well. So for us on the left-hand side, that's at West Yorkshire level. That's our integrated care system level. And on the right-hand side is how we operate across our 5 places. And I've got another slide in a minute that I'll share with you. The key point at the top of that slide is that the strategic aims are set by our health and wellbeing boards. They are setting out the aims, and what Toby was particularly talking about, the outcomes that we're looking for our populations. Our common aim, our common purpose is about reducing health inequalities and serving our communities. And then our partnership board over on the left-hand side particularly is then bringing that together, which comes into that strategy of the 10 strategic aims. We've had place system committees and health and wellbeing boards meeting together for a number of years now, and James has particularly been part of that in Bradford District and Craven, but we'll formalise that soon into the place committees, and we're particularly recruiting at the moment for independent chairs for those committees to work alongside health and care leaders as facilitators to achieve what they want to together and be accountable for the delivery of that health and wellbeing board plan in the local area. That then links up to the new ICB, and that's how we plug in, and my role particularly in making sure that we're accountable and we have oversight. And you'll see there, if you're a real governance geek and want to get into the hierarchy of assurance and the committees that sit there, you can see in those blue boxes how that all connects together. What you're probably thinking is, how do we navigate what NHS England is asking us to do in terms of key priorities, such as elective recovery, alongside trying to achieve the Health and Wellbeing Board aims? What we agreed at our last partnership board in early March is that we have to navigate them both, and they have equal weighting. And how we put our dashboards and our board assurance frameworks and our corporate risk registers together, both at the place committee and for our integrated care board, will aim to achieve this. So if we just move on to the next slide, it's sort of reiteration, because some of you might be wondering where our provider collaboratives plug in. And they're there as specialist, set for specialist services. And you can see there on the left that we have our acute provider collaborative. We have one for mental health, learning disability and autism. I used to chair that in my previous provider chair role in Bradford. And we have a new community services provider collaborative coming through at the moment, which very much has a common aim of the outcomes for local populations, but it's complex in working through how voluntary sector, particularly social enterprise providers, work alongside NHS providers and GPs as well, and community pharmacy. And then you can see then how it all plugs in together, beginning with the 5 places in the neighbourhoods at the top and the outcomes we're aiming to achieve, and particularly around tackling health inequalities, as well as you can see at the bottom there, navigating the work that we need to achieve for NHS England. And the next slide, I'm just making sure that I've got enough time to hand over to James, particularly then reflects our participation and how we bring in community voices into what we do. We already have active participation strategy and delivery in place. Some small examples for you. We have a nomination process that we'll have someone from Healthwatch sat on our integrated care board. We're about to do a recruitment process to have someone from the voluntary and community sector sat on our integrated care board as well. And we've commissioned Healthwatch to particularly bring together a people's board for us to have a connectivity to our integrated care board. So if you're from a foundation trust, you'll understand that kind of model and how you have the trust board connecting with your council of governors as well. And in provider collaboratives, the more obvious thing is around working with people with lived experience, service users, to inform service transformation, which is also what's being embedded into place committees. So that's an overview for you. If we just move on to the next slide, please. And it's about moving into this new way of working, and Toby touched on this already. We use the terms value added a lot. What is the value added that a place system can bring? What's the value added that West Yorkshire can bring? And it's making sure that we're putting the right intervention into the right part of the system. And it's not that we're moving from one side to the other. Our chief exec, Rob Webster, and I were talking about this yesterday. It's an ecosystem, it's the solar system, and we're trying to work out the right intervention at the right time and the added value that will bring. And sometimes it's right at neighbourhood level with community pharmacists and GPs and voluntary sector. And sometimes it is up at that acute, that provider collaborative level. For example, with our acute provider collaborative coming together at the moment in tackling elective recovery. So that's an overview. There's a lot of information now. I'd really encourage you to go onto our West Yorkshire Health and Care Partnership website. There's particularly a lot of information on our provider collaboratives, especially for our acutes, as well as an overall ways of working and an example of our constitution for our integrated care board. So if we move on to the next slide. Thank you. I'm going to hand over to James now, who's going to give you a snapshot of how we work in one of our places in West Yorkshire. James, over to you.
Thanks, Cathy. Next slide, please. And the next one again. So, lots of what Toby said already and Cathy said already strikes a real chord with us. We've been trying to work as a partnership for our place for many years, and you could probably trace some of our roots back to collaboration around particular pathways of care or disease-specific requirements over probably 10 years, but certainly for the last 7 years, we've been trying to work as a partnership around all aspects of health and care. And so my first point would be, this stuff doesn't happen overnight. You can do the governance, you can write whatever sort of charts and arrangements that you want to have, but that won't get you there. You know, we've heard already that systems are organic, they're not just a machine, but you do need to have clarity of how things will work in order that people will engage with it and build trust. And that second thing there, SPA. So that's a strategic partnering agreement in Bradford District and Craven. And several years ago, we set out to write down the rules of the game, if you like, for our partnership, our collaborative agreement, how we would do things. And we did that because we wanted to share decision making. We knew that rather than viewing that commissioners in a CCG, for example, had all of the knowledge needed to make the right decisions about what to do next, and that they should just be the only people making and taking those decisions, we would make better decisions if we had all people, providers, commissioners, representatives of community groups, people beyond health and care in the room shaping and making those decisions. But we would still at that point, because of the legislation at that point, have to formally take those decisions through the mechanisms of our individual organisations. That transaction was still happening in the old way. And we're really happy that the changes brought about by the new Act enable us to do both the decision-making collectively and the taking through our Committee for Place. The other thing that's really important for us about how we go about this is distributed leadership. So we don't have a place lead in Bradford District and Craven who is just the place lead. We've asked one of our Trust Chief Executives, Mel Pickup, to fulfil that role alongside being the Trust Chief Exec. And in order to do that, both from a point of view of capacity, but also because we really buy into the notion that you know, more heads are going to be stronger than one on this, that we have a process of distributed leadership. And so our Chief Execs from our council, our Director of Adult Social Care, our Trust Chief Executives, our executives that lead on primary care and lead on social care provision, for example, and voluntary sector, are all taking roles to lead on particular parts of our system. We're trying to play that same approach out to all tiers of leadership within our place. So it's been right for us to establish partnership governance and a partnership board as a committee of the ICB. You'll have worked through some of those changes and options that were there to do it a different way. I'm happy to talk a little bit later if you want about why we chose that route rather than one of the others. The key bit here is that partnership governance and the chart that we will need to demonstrate to folks to give them the clarity about how we're going to do things and to make sure that delegation can flow to us here is only part of the picture. That subsidiarity really doesn't stop at the board for place. We've got 13 community partnerships. We've got numerous transformation programs. We've got many other ways in which this needs to happen. We're trying to get decision making as close to people as we can. And we're trying to make sure that our operating model is aligned and matches with those same principles and that same way of working. Next slide, please. But of course, none of this matters, none of the governance arrangements matter unless it makes a difference for our people and our place. And that's what grounds us here. So you can see there, this is a big area. You've got something like 600 square miles, 450 square miles of which are in the Craven district part of this to the northwest. And in people terms, we've got nearly 600,000 people, but only about 55,000 of those are in the Craven part. So really different, really diverse communities that we're trying to serve. And our purpose here is to make a difference with and for our people. Next slide, please. And we think that we want to enable it to enable us to do more of these kinds of things. We've got a good track record of working together. It builds energy, it builds connectivity between us, it binds us together and makes those bold statements about what we want the world to be like into a reality. And for example, then that doesn't just mean that we all hold hands nicely and we're great friends, but we're doing things. So around COPD, we've been able to pull in resources from outside. We've been able to give people with COPD the ability to manage their condition with an app, with the support of a digital care centre. We've been able to expand that out from what started as a COVID-related approach. And all of this we call our Act as One approach. And that came from our people telling us that that's what worked to enable them to do good things. So you will have experienced this as well, that during the first flushes of the pandemic, there was no governance really around how we did things. We knew we needed to act, and we knew we needed to do things differently. And we really wanted to empower all our teams working with each other and with communities to find the right way of doing stuff. Experiment, as Toby would say. And they did. And we've tried to really bottle that approach and enable them to do it. And our governance is designed to enable our teams to act as one and support each other and to engage people in doing that. Next one, please. And so we set that out in our strategy. It's a bit little to see here, but the bit I really want to draw to your attention is in the middle, our purpose. So narrowing the gap, we're trying to make sure that we reduce inequalities within our place. And we've embedded that in our governance, we've embedded it in things we ask of each other and the things that we measure. We know that means taking an approach which is about equity and justice, not about doing the same thing everywhere. And that necessitates working differently with different communities and decisions being made at the right level. So inverting the power to act, sharing that responsibility, passing that on to those community partnerships and letting them try things out so that they can then make those right decisions and they can engage people at a level that matters to individuals. And our workforce, wrapping around that, being able to empower them and support them to work in that way, work with each other and remove barriers to them doing that, that's key to us too. And stewardship, so thinking about future generations, you know, we're holding this for now on behalf of our future generations, and that runs through what we're trying to achieve in Bradford districts and Craven. Next one, please. So this is how we set it up. And this is just a version of what you've already seen from Cathy, really. So you can see at the top of the page there, the NHS West Yorkshire Integrated Care Board, delegation down to the Bradford District Craven Partnership Board. That's our place committee. It will meet in public. It will, we've already started meeting in shadow form. It will take the big decisions really for our place. It's empowered to enter into agreements with local authorities so that we can do more of that joint commissioning. And we've got a planning and commissioning forum that does more of the driving and nuts and bolts of that kind of thing. Really important as well that we can do this stuff on a day-to-day, week-to-week basis. So we've got a partnership leadership executive, and that's chief execs largely, plus sector representatives for social care, BCS, primary care, etc. All meeting together regularly to drive forward the business of the partnership and to align what we do as a system. Important to note that's really worked, and that's been the bedrock of our partnership arrangement for the last sort of 5-6 years, and it's managed to do most of what it's done so far on the basis of system leadership, of convening, of finding consensus around issues, not of having a big governance stick to wheel to make anybody do it. It's really been about a partnership approach. And you can see there beneath the partnership leadership executive a range of ways in which the delivery happens, whether that's around particular subject matter like mental health, learning disabilities and neurodiversity, or whether it's around particular focus on children's health and wellbeing, which is really important for Bradford with one of the youngest populations in the country, or some of the others are around the geographic differences within our place. And you can see there those health and care partnership boards. One last bit of the governance that's worth drawing to your attention are the committees. So these are committees providing joined up assurance on finance performance, quality, and our workforce people. We're looking at how that we will blend those together so that we can provide coherence, recommendations and advice to the partnership board on its decisions. And it's really important that we're doing this stuff, not just in public, but involving the public. So there's a citizens forum that connects to a network of all of the different routes through which the people connect together and have their say about what they want for themselves and their communities. And similarly, a clinical forum to really make sure that the things that are being formed here are recognising the needs of the workforce from a clinical and professional perspective. So that's the nuts and bolts of the governance arrangement. And I've just got to think of one more slide, please. Next one, please. Which is just to say, sorry, just flip past it. Sorry. Which is just to say who is involved in that. You can see there the list. It will be a similar list to those that are involved in your place partnerships as well, because we've followed the sort of the expectations. But it's a big board here. It's a big board because of the multiple organisations, the multiple areas that we're covering. So we've got 3 local authorities, we've got 3 foundation trusts, etc. But one of the bits that is probably worth drawing out finally is just to say that for us, we wanted to put everybody who's a member of this board on the same footing, so that we don't have 2 tiers of arrangement here. We value everybody's input to it. And because of the partnership history that we've had together, we're confident in doing just that. Had we been starting afresh at this point, then that might not have been possible. But because we've been walking this path for a long time, it really is to our benefit that we can draw upon the full input of all of those wider range of partners that you can see listed there. So at that, I'll pass back to Cathy, please.
Great. Thank you, James. So we've just got a couple of slides left. Our next slide just shows some common campaigns that we have together. One is the anti-racism movement that we have. So you saw in James' slide how Bradford is supporting that, and that we are, and that links with one of our strategic aims to have greater diversity in our health and care leadership. And we have other campaigns that we run together across West Yorkshire that then unite everybody. I wanted to give some examples of ways of working. And one thing we keep our combined authority close to us, and we've actually now got a shared public health role. So I think that's very important for us in looking at those wider contribution that the NHS can make to social and economic development. We're working very openly with our local authority colleagues, and an example of that is where we could find small amounts of surpluses over the previous winter. We invested £12 million as a one-off intervention into social care to support care workers during the winter period, because it was a very obvious thing that their wages weren't going to increase at that point, and we wanted to maintain them in those services. So that's the way in which we're trying to pool money and work together at the moment. But there is something about keeping public health close to your work rather than keeping them at a distance. And I'm really pleased that they're supporting a number of our NHS provider boards at the moment to look at how they can have a board assurance framework and looking at tackling health inequalities. So our last slide is just talking about, if we just move on, our mission, vision and mission, values and behaviours. Now, you work within a trust and within a service provision to make sure you've got the right kind of culture. But what we're trying to do is across the system by place and across the system across West Yorkshire. And that's particularly, James talked there about subsidiarity. We particularly aim to suspend egos. We see diversity as a strength, and we have a willingness to share risks. And we can call each other out when that's not working. But this is our bedrock of how we work together in our system. So we could talk a lot more about our ways of working. We're very proud of our partnership, and we're on a new era for ourselves from the 1st of July. And please go onto our website to have a look at it. But yeah, thank you again for the opportunity to speak, colleagues at NHSP.
Brilliant. Cathy, James and Toby, thank you for those really interesting presentations. We've got just under 20 minutes left, so I'm going to dive into questions which are starting to come in. First from Anne Waitley. How are you handling the shift to local collective decision-making and the relationship with provider boards? Are you involving NEDs in the place committees? I think that's probably one for you, Cathy.
Yes, well, I think particularly James as well. So
okay.
James, perhaps you want to talk about how those committees under the Place Committee are working, how leaders are coming together collectively.
Yeah. So I think the first thing I would say is that our trusts have been involved in forming this every step of the way, and that's both through the chief execs and the exec teams being involved in shaping and developing the proposals, chairs of trusts meeting regularly, so we have a chairs and elected members reference group that's helped to guide and shape some of these things, and we've also got a series of events for trust board members as well, and we've tended to do those along with similar type non-exec roles from local government or from voluntary community sector organisations. In fact, we've got one next week, which is our latest one, to say this is how those component parts of our system are intended to work and how that would fit with your trust board and in its working. And folks like myself have been visiting the trust boards fairly regularly over the course of the last year, at least 3 times to each board, just to sort of keep in touch with the journey. And then to the point that Cathy made, our committees, those finance, performance, quality, people committees, are chaired by non-executives of our trusts. And when they're chairing those committees, they'll be wearing a system hat. So being a non-executive is their ticket into that world. But what we're asking them to do is to act on behalf of the whole population there. So each of those committees has 2 trust non-executives, so 6 in total, drawn from across our 3 trusts. And we're really proud that will help us to form more connectivity between the different parts, between the organisation and the system.
James, thank you for that. Just a reminder to our audience that you can put in a question. You go to the Q&A box at the bottom of your screen, and it's session 9, and then you can post your question. We've got another one here from Amanda Moat. Can you give progressive examples of where these governance structures have changed the discussion and board measurements to a more balanced outcome focus on safety and harm or health aims, and where these have percolated into providers of care? Starting again, probably with you, James.
Yeah, I think from a principal point of view, then what we tended to find is that our provider organisations are now far more connected and far more aware of the things that happen outside their 4 walls, where they operate primarily within a hospital setting, and that might be around, for example, sustainability and what impact we're having on the environment around us, and how we can collaborate with others in terms of what we do with the built environment, or it might also be around what happens to people before or after they're in a hospital setting, and so we've tended to see more collaboration at a clinical level between, for example, consultants working in primary care or vice versa, or inviting in voluntary community sector people to work within the hospital. So we've got a thing that we call the MAST, the multi-agency support team, which is voluntary sector led, delivered within a hospital setting, and they provide support for people who would be attending an A&E or admitted to a ward. So that, and what I've seen, I think, probably is a greater level of trust and understanding of the capabilities of each other through doing that kind of thing, which only leads to further possibilities once we start to do that.
Adam,
sorry, Cathy.
Just to come, there are so many examples. So the one is around our West Yorkshire Cancer Alliance, which you can have a look at online, improving outcomes and the connectivity of pathways. In Bradford, because I've come from that place, is this particularly look at children's services. So a frank discussion and reporting collectively on the state of children's services and the action plan that needs to come forward, and a current review on out of hospital care. And our colleagues in Wakefield particularly now have a joint role for community services, which goes across the current CCG, the council and NHS services, which is really supporting integrated discharge at the moment. And then particularly within provider collaboratives, the mental health one, they've been looking at lots of different things, including collaborative shared services with one lead provider on assessment treatment units, as well as how do you have a common way of delivering and ensuring a common approach to prevention of and management of violence and aggression in patient services. So there's quite a few examples people can look at on our website, but the governance and the memorandums of understanding and the code of conduct are really helpful bedrocks to try and have these conversations and transform services.
Thanks for that, Cathy. So just curious to get a sense from you, Toby, in terms of what we've been hearing about what's happening, obviously in West Yorkshire. I definitely picked up sort of the resonances of what you'd been talking about in terms of the human learning system. We were hearing about decision making being taken as close as to people as possible, empowering teams, allowing them to experiment, particularly during that pandemic period. There was, so I'm putting it bluntly, was there a lot to like in what you were hearing there? And how helpful do you think that the examples we've been hearing from West Yorkshire, insofar as they meet the model that you're advocating?
Absolutely. I was nodding and clapping on considerably to a range of the things that I was hearing there. So exactly as you highlighted there, Adam, the focus on enabling workers to come together and experiment in order to address the purpose that have been identified at a strategic level. Exactly the right approach. That sense of that partnerships make strong expressions of this is the purpose of what we're for in kind of principle terms, and then that kind of distributed leadership approach, empowering different kind of staff bodies to go, okay, and how might we do that in this context? Exactly, those mirror kind of in a quite spooky way a bunch of the case study examples we've seen of people kind of making a human learning systems approach. The questions that I am kind of would be keen to explore with kind of Cathy and James is at a kind of partnership governance level, what how are you how is it those governance arrangements question and keep abreast on the learning that is happening coming up from below? So what's your role in enabling those learning cycles to happen effectively, and by what means are you kind of able to see the patterns from across all of the different types of experiments that are happening and begin to say, okay, what are the things that we need to change at a partnership level in order to enable that work to continue to happen more effectively? So the questions that I would have for James and Cathy are, how is the partnership continually changing its way of working, its approach to governance on the basis of the data that's coming up from all of that experimental work?
So Cathy and James, I'm going to invite you to pick up on that in terms of how you facilitate those learning cycles and how you adapt in real time.
So I think there's something about which is what you're offering us today from NHSP, is getting people together to share practice. So last week we had our second West Yorkshire trauma-informed care conference over 3 days with the Yorkshire Violence Reduction Unit. And that was an opportunity for practitioners to come and share their practice, as well as for us to invite speakers, national and international speakers, to come and talk to colleagues about good practice. So there's something about convening, and I really feel that integrated care boards and integrated care systems need to convene practitioners and those working in policy and public health. There's also something around tracking against our strategic aims. So our last partnership board, we had our strategy on suicide prevention, which you can go online and see through our partnership board papers, which are in the public domain. And it was about sort of reflecting on where we are now and where we need to go next, and particularly better connectivity in GP services, but frankly, better funding. But we've got a lot more autonomy now to try and look into that, as well as looking ahead on what we can do on broader economic issues, because a common contributing factor, if we go back to your point, Toby, in that messy graph, sometimes one of the contributing factors to suicide for men particularly is a bit unemployment. So I think there is, Toby, it's work in progress, but one thing we're doing is convening people, whether it's a place, provider collaborative, or because they're working in a common area like trauma-informed care, to come and share best practice so they can learn from each other. And another example is in Wakefield, where we have one person working across 3 different organisations on community services, and now we're working to replicate that in 2 other places across our 5 systems.
Cathy, thank you for that. James, do you want to come in?
Yeah, just briefly. So there's something for me about, this is not necessarily about good things have happened and we have to send it back up the tube and then sort of find an answer there. It's often about connecting people to each other so that other teams can learn, can build on the experiences of others, while respecting the fact that every neighbourhood, every team, every setting is different in its own way. So we can't just necessarily lift and shift a good idea and expect it to flourish elsewhere. So a festival, Act as One Festival, is something that really helps us to connect more parts of our system to themselves. And we're also working with the Health Foundation on the notion of an innovation hub, which is intended to take those good ideas, those evidence-based good ideas, and work out what would help us to make them flourish in a new setting, and what would work there. So we're trying to take a learning approach to just that question. And so that's probably the other thing that's worth mentioning around some of our mechanics for this. So it's not about a control thing, it's about learning and sharing.
May I ask one more question, Adam?
Yeah, if you could, let's do this quickly because we've got a couple more lined up. So yes, Toby, and then a couple of
if this isn't the most relevant, feel free to move on. But how is that translating at a kind of ICP and ICS level into commissioning and contracting differently? So how are you, from what you're learning and to kind of enable that experimentation, learning and adaptation, how are you contracting with organisations differently so that the contracting is focusing on enabling learning and experimentation rather than delivering against predefined service specifications?
So Toby, I think the most interesting, I think if you ask that question in a year's time, when we're set up as statutory bodies, when the money can be worked in a different way, I think we'll be able to share some wonderful examples with you. I think through our mental health provider collaborative, that's given us the opportunity to have a lead provider approach with a risk sharing agreement. So out of 3 or 4 mental health providers across our patch, they have agreed that one of them will take forward and be the West Yorkshire lead for West Yorkshire service. And it's been a real, it's lived and breathed all our values and behaviours, but we need to see it in practice, whether that's assessment, treatment unit, forensics, for example. So I think we've got some pockets of examples of how you then bring the money together, because we have to work in the reality of the budgets that we have, but the quality of service improvement that comes from that. So there's a number of examples, and the provider collaboratives have been a really key bed and foundation for that. But I'm really interested, I'm excited about what happens when you get into your first statutory place committee meeting with the same budget you've had for years, but how you can think about doing it differently. And in Bradford, their Director of Adult Social Care now has a joint role with the local NHS Mental Health and Community Services. So what can come from that as well?
Thank you for that, Cathy. We do have 1 or 2 questions that have popped up, so I'd be keen to introduce at least one of them in the time we have remaining. Given Toby's introduction of the theory, how assured are Cathy and James that all actions are meeting the needs of the whole person, given the codependencies of housing and other factors outside the direct remit of the ICB? And that's from Sarah Anderson.
James, do you want to start from a place perspective?
I would say that there are partnerships that overlap with each other. So I can tell you about the Health and Care Partnership and what it does, and which is far more than just delivering on health and care services. All of us are also part of our economic partnership, our Sustainable Development Partnership for Bradford District, for example. And so thinking about our broader contributions there in how we do those things is part of it, and reaching out to form those broader connections is part of how we do things. But I wouldn't necessarily expect that is front and centre in our conversation as a health and care partnership board, because we've got particular things to focus on there. But we recognise that the governance is only part of the picture. It's that messy, organic set of connections that was described, and being comfortable working in that way is probably the thing I would.
And I suppose the other point, I know we're running out of time, Adam, but at West Yorkshire ICS level is then particularly working alongside the Combined Authority and our Metro Mayor. Simple things like a mapping exercise of where we've got common aims and ways of working together, which is why we now have a shared public health role. And how we navigate, if you remember that chart I shared earlier, how we navigate delivering what NHS England needs, as well as what health and wellbeing boards need. And we're doing some work at the moment on our intelligence and data sources to make sure we can track outcomes, which is what Toby's encouraging us to do, as well as specific targets we may have, for example, from NHS England. So, but it's the interest of having that broader economic and social contribution as an NHS, which is the fourth purpose of an ICS.
Okay, thank you. And so one very brief final question, this one from Marnie Hayward. How important do you think councils of governors are in helping provider collaboratives to drive connectivity through community partnerships? Do you think it's more challenging for provider trusts stroke collaboratives that are not foundation trusts?
Oh, my favourite topic, governors, and we were running out of time. So one thing we've done through the provider collaboratives is governors have been briefed at least every 6 months, if not every 3 months, alongside non-exec directors. They come to events to be briefed on what's happened most recently in terms of service transformation and what's happening next. You then can take them with you as you then get back into your trust and talking about risk sharing and service transformation. So they do play a role. I think we're all trying to find our place at the moment in these legislative changes. So a governor's main purpose, of course, is holding to account their foundation trust. But if you don't have them, there's still public representatives you need to involve, whether that's service users or other local elected officials like local neighbourhood councillors. So they do play an important role. I'm particularly being active at the moment, inviting governors in foundation trusts in places to submit public questions to the Integrated Care Board for our first shadow meeting next week. So we mustn't forget them, but I think we've all got to work this out together.
Cathy, thank you. And so that brings us to the end of this session. I hope you've enjoyed it. A big thank you to our speakers, Toby, Cathy and James, and to you for your questions as well, to bring this session to life. I don't think it needed much bringing to life, actually. I think the presentations were excellent, really interesting, and a really good discussion.